Okay, so much about repetition, and here is the underlying evidence. So you see these larger prospective randomized controlled trials that had looked at blood pressure lowering in acute ICH. You see this is the outcome, good functional outcome, and you see this tends toward favor of vasodepressors of the intervention, but it is not a significant result. Same holds true for good functional outcome when it comes to time until treatment, so within 6 hours, within 24 hours, and 72 hours. And you see there, it seems to be that there is a time effect on the speed until you lower the blood pressure. This is death within 3 to 6 months overall, favoring the intervention. And this is, again, that outcome, death within 3 to 6 hours, according to time until treatment. And again, there is a trend towards an improvement with the intervention, but not significant. Same is unfortunately true for hematoma expansion. So this is borderline. This is hematoma expansion overall, and this is hematoma expansion by time. And what that shows you is what we all know, that the earlier you come and the earlier you treat, the higher is the probability to reduce hematoma expansion. This leads me to the third section of the guideline, which is on hemostatic therapies. These are the PICOs that are covered in that area. So this deals with spontaneous ICH. In other words, with patients who have no changed coagulation, and dealing with the question of does factor 7A is of any benefit, tranexamic acid, then spontaneous ICH with antiplatelet drug use. How about the intervention with platelet transfusion and desmopressin? Then the area of anticoagulant-associated ICH, differentiated by the use of vitamin K antagonists treated with, vitamin K antagonists treated with prothrombin complex versus fresh frozen plasma. And then comes the section of ICH associated with factor 10A inhibitors, dealing with prothrombin complex, andexanet alpha, tranexamic acid, and idarucizumab. This is a summary of the recommendations. So we say there is weak evidence against the routine use of recombinant factor 7A outside of clinical trials, and the same is true for platelet transfusions. We give an expert consensus statement to consider PCCs in vitamin K-associated ICH, to consider the use of andexanet alpha in factor 10A inhibitor-associated ICH, and to use idarucizumab in patients who have bleeding while they are on dabigatran. So this is an example for where we do only, in parentheses, give an expert consensus statement, and the reason is because this is all about clinical outcome. Let's continue with the case. After the patient deteriorated and the patient received another scan, and what you see is hematoma expansion. This leads us to the question, how should we proceed here? What about new surgical interventions? And that is section 4. And section 4 deals with these PICO questions, divided in supratentorial ICH and infratentorial ICH. And supratentorial ICH, we also asked for the question, what are we going to do when the bleeding expands to the intraventricular space? Let's start with any surgery aimed to hematoma removal. Question is, in adult people with acute spontaneous supratentorial ICH, does any surgery aimed to clot removal versus no surgery reduce the risk of death or dependence? And this is the recommendation. In adult patients with acute spontaneous ICH, we suggest for a surgical approach aiming at removal of hematoma removal and prevention of secondary brain surgery to reduce the risk of death or dependence. And now comes the important part, taking into account additional factors such as hematoma location, hematoma volume, patient's neurological condition, timing, method of intervention, and the surgeon's complication rate. And this is why this is followed by another statement. Given differences in results and quality of evidence for surgical interventions, recommendations are further specified for craniotomy, minimally invasive surgical removal, and surgery with catheter placement plus thrombolysis. Let me pick the PICO on minimally invasive surgery. The PICO is in adults with acute spontaneous ICH, supratentorial ICH, does minimally invasive surgical removal of the hematoma versus no surgery reduce the risk of death or dependence. The recommendation is in adults within 24 hours after spontaneous ICH, supratentorial ICH onset, we suggest minimally invasive evacuation of the hematoma to reduce mortality and to improve functional outcome in adults with lobar ICH. Pronunciation on lobar, whereas the effect in deep hematomas remains uncertain, so we encourage recruitment into ongoing randomized controlled trials. And the reason why you see this, why we came up with this recommendation is this evidence. You see that we have divided, first of all, you see that we divided the evidence into the approaches. So when you look at the literature, you'll find that there are that you can differentiate between neuroendoscopic and stereotactic aspiration and what we call tubular access of the hematoma. And here you see the respective studies in all of these areas. And when you look at the overall result on clinical outcome, you see that there is a significant result on death at 3 to 12 months. And when you look at good functional outcome, you see again there is a clear clinical result in favor of minimally invasive surgery. The other PICOs I will not tell you in detail, I just tell you what we recommend. There is weak recommendation for decompressive surgery in deep ICH for volumes between 30 and 100 milliliters. There is a weak recommendation for applying external ventricular drainage with intraventricular thrombolysis. There's also a weak recommendation for evacuation of cerebellar ICH larger than 15 milliliters. And we are giving an expert consensus statement for considering the use of extraventricular drainage. This leads me to the fifth part of the guideline that consists of the following PICOs. We differentiate between single measures and care bundles. Single measures relate to physical measures to prevent venous thromboembolism, short-term antithrombotic therapy to prevent deep venous thrombosis and pulmonary embolism, temperature management, blood glucose control, intracranial pressure monitoring, anti-inflammatory treatments, and anti-seizure medications. So each of these have are PICOs, and we recommend against the use of temperature and or glucose measurement as single measures. We make a strong recommendation against the use of anti-inflammatory drugs outside of clinical trials. And we give a weak recommendation against prophylactic treatment with anti-seizure medications. We provide an expert consensus statement to consider ICP monitoring if clinical symptoms monitoring alone is not feasible. A few words about care bundle. The question is, in adults with spontaneous ICH, does applying a specific care bundle compared to with the usual care reduce mortality or dependence? The recommendation is, in adults with acute spontaneous ICH, we suggest implementing a care bundle to reduce death or dependence, and we further specify this in an expert consensus statement, because one other intention of our recommendation is we want it to be as practical as possible, so you will see more than only this one expert consensus statement where we talk about dosing and timing and so forth. So concerning care bundles, we recommend to implement a care bundle that includes early intensive blood pressure management, control of elevated blood glucose, treatment of pyrexia, and, if needed, reversal of abnormal anticoagulation. Why did we include these four? We included these four because they are the ones that are studied in a prospective fashion. But we discuss that there are other trials that looked at other aspects of a care bundle, like avoiding do not resuscitate orders, dysphagia screening and treatment, and early consulting of neurosurgeon, in other way, having a pathway ready if it comes to the question of intervention, neurosurgical intervention or not. And of course, we recommend inclusion patients in randomized trials of care bundles. This is the meta-analysis of the INTERACT-3 trial that builds the base for the recommendation, and this is the outcome, good functional outcome defined by modified ranking score of 0 to 2 at 3 to 6 months. And this is about death, again, showing a benefit of a care bundle intervention as used in the INTERACT-3 trial. This leads me to the last section of the recommendation, which is about secondary prevention. And this covers a PICO question about blood pressure control, the use of oral anticoagulants, the use of or the application of left atrial appendix occlusion for patients with an ICH and atrial fibrillation, for the use of antiplatelet therapy, and for statins. I summarize this in this table. So we give a strong recommendation for blood pressure control, lowering to a blood pressure of below 130 over 80 millimeters of mercury. We give an expert consensus statement to consider left atrial appendix occlusion consider in patients with a prior ICH or inclusion in randomized controlled trials. We give a weak recommendations for restarting antiplatelet therapy for a licensed indication. We give an expert consensus statement to consider statin use as primary or even secondary prevention. I think the current main message in ICH is to recognize that the earlier therapy, the better is the prognosis. And you may all heard of that there are papers out now more and more about code ICH, pronouncing that what we know from acute ischemic stroke is true for ICH, and that is time is brain. I'm very happy and proud to tell you that this guideline was also published like the other 3 guidelines today. And I'm even more proud of having worked together with these colleagues. Thank you very much.
I just want to echo Professor Steiner that the guideline is available on ESJ website. We just downloaded with Diane a couple of minutes ago. So feel free to go and download the guideline. I think we have a lot of reading to do, all of us. So the floor is open for questions. We have 6 minutes. Yes, please.
Hi, Alex Polberg from Switzerland. I was wondering, given that you now explicitly recommend minimally invasive surgery for lobar ICH, do you comment on the particular technique and devices that should be used? Or would you say this is something that's open, to the individual sites?
Yeah, I mean, it would be unrealistic to say we have to use what was used in the ENRICH trial. And you probably, many of you have heard about that there are other trials that, again, have shown that there might be a signal when there is a lobar approach, but not for, when there is a lobar ICH, but not for those patients who had a deep ICH. And they obviously use different devices. So if you ask a neurosurgeon, I hope I'm not going too far, they will tell you it's the way you approach, it's the timing, how you approach a lobar ICH to get to the results we have seen in the ENRICH trial. But ENRICH is the only one trial we have at the moment, and I think we need to see other trials on new surgical approaches to tell us that these are results we can replicate.
Professor Tiscaridze.
Thank you very much. Nice guideline. My question is, didn't you cover restarting anticoagulation for secondary prevention in patients with AF and ICH?
Yes, we do. Yes, we do. We are saying you can, in certain adults, you can consider to restart oral anticoagulation. Yes, but as I said, it is. I think it is a good advice to read the guideline because there is a lot to say about that.
We have a question in the left side.
Hi, David Rose from Tampa. Any blood pressure variability specifics that were mentioned in the guidelines, or just kind of said, try to control variability? And then secondly, about andexanet alpha, a lot of places are moving away from it given its thrombotic risk profile. Your thoughts on that for DOAC reversals?
Okay, about variability, the recommendation is keep it in a range between 130 and 150. The problem is, as you may know, and here I'm biased, the question is, do we use the right drugs? But this is something you should ask yourself. I don't want to comment on that any further. Yes, but the bottom line is the smaller the variability, Adnan Qureshi has shown that, for example, the smaller the variability, the better is the outcome. That's the trend. And yeah. Try to keep it between 130 and 150. That's the message.
There was also a second question about the thrombotic effects of andexanet alpha.
Yeah, that's why it does make the recommendation so difficult to weigh between the benefits and the risks. No doubt about that. But here it might come a little bit emotional. It is no question for me that there is a hemostatic effect, right? And so, do we really think that in each of the patient I reduce hematoma expansion, but at the same time I will create a myocardial infarction? Of course not. And I think this is something we should have in mind. We deal with a disease that has a mortality rate of, depending on where you are, between 40 and 60%. So would I really hesitate to use andexanet alpha in a patient who is, let's say, 50 years old and has clear, is, let's say, on whatever oral anticoagulant, and I know that there is an elevated level of that substance, would I really refuse to treat with andexanet alpha? I would not.
Professor Steiner, I have a question before I give the floor to Professor Fischer with regard to andexanet alpha, and it's a technical question comparing American Heart Association guidelines with ESO guidelines. So in 2022, American Heart Association guidelines, based on one positive trial on hemostatic efficacy, they gave a grade of recommendation of 2B for andexanet alpha for factor 10A11 associated intracranial hemorrhage. Now, after a second positive trial for hemostatic efficacy focusing only in patients with intracranial hemorrhage, ESO guidelines give an expert consensus statement. They downgrade the recommendation for andexanet alpha. I think this needs to be made very clear to our audience about different methodological aspects between American Stroke Association and ESO guidelines. So can you please elaborate?
Yes, I can. So, as I said in the beginning, this is all about clinical effect on patients, or benefit for patients. And the problem is, as you probably all know, the problem with andexanet alpha is that we do not have an outcome that is the usual outcome. The usual outcome would be either hematoma expansion, and it is hematoma expansion in a surrogate parameter, but unfortunately what we have here, we have a combined parameter that includes hematoma expansion, clinical outcome, and the need for a second dose or another dose of whatever, rescue therapy, PCCs, for example. And that makes it so difficult. But when you analyze only the piece of death or clinical benefit, then you don't see an improvement, a clinical improvement, a signal for that. But you cannot neglect that at the same time there's a clear result on hematoma expansion. And this is why this is different. This is why we don't give a recommendation. We stick to our first goal, and that was looking at the clinical benefit for patients, but we give an expert consensus statement. That's the reason.
Professor Fischer.
Yeah, first of all, thank you very much for this tremendous work. We all know providing such a guideline, it takes weeks and months. And I would like to follow up the question from Alex Polymeris before. It is interesting that you recommend minimal invasive surgery for lobar hemorrhages, but on the other hand, you also say that you need more trials, more evidence. And this is quite tricky, because if it is in the guideline, and now in the European guideline written, yeah, minimal invasive surgery should be done in people with lobar hemorrhage, how do you want to include or convince people to be randomized in another study? Because then they say, well, it's in the European guidelines already written that you should do it. What is your comment on that?
Yeah, I think the goal was that we make people think of location, and I think the question is still open whether these techniques can be applied in patients with deep hemorrhages, and this question is open.
I fully agree, but do you think we need more evidence for lobar hemorrhages? Because we have, well, basically one trial which was supporting that.
Yeah, I think we need confirmation on that.
But again, then you are now in the deadlock, with the guidelines saying you should do it, but on the other hand, you recommend it also for the lobar ones.
Good point. Let's think about a design.
Thank you.
It's also a weak recommendation. A weak.
It's a weak
recommendation.
recommendation.
It is. Yes, of course. It is a weak recommendation, yeah.
So thank you very much for all the wonderful talks, and thanks from my co-chair and all the guideline boards on the work on these guidelines. So I invite you all to download the papers, and we today had really great discussions. If you have suggestions on the guidelines, please drop us an email. There's also a comment box on the website. I hope you can take these insights into clinical practice and enjoy the rest of the conference. Thank you.